Certainly, the Dr. Saul's statement that knowledge is wellness resonated, and we have a couple of questions for him about the wellness program. How did you recruit the wellness ambassadors, and what kind of training did they have?
Through a variety of ways. There was a program before I got started with the program. There was a program here where we were going out into the community, in Brooklyn particularly. And so several of the wellness ambassadors had been part of that program, and they wanted to stay with Rogosin in the Rogosin that we were doing. And we went to, I'm going to say, dialysis units, social workers, some of our home units, and they actually pointed us in the direction of different patients, different people who would be peer mentors. We interviewed them, and then we actually have a training program for them. We have a training program so that they can develop their skills as wellness ambassadors. I think what's great is the way Candace described the wellness ambassadors. I've been doing this for a long time. I learn from them all the time. They're very, very knowledgeable. And they're very knowledgeable about, and I'm going to say also, the nurse who is involved with the Llewellyn program, Yvonne Perry, I learned about barriers. How do we overcome barriers? How do we go to dialysis units? I learned from the patients, and I learned from the wellness ambassadors. And that's how we're developing the program. We have a formal training program for them, but it's not where different people talk about home dialysis, transplant, et cetera, et cetera. So they have background.
Great, thank you, Stuart.
Thanks. And there's a question about, is Rogosin collaborating with business and organizations in the community where this program is located?
We're not doing that right now. I don't want to be diffuse. I'm very focused on getting started in the dialysis units in certain places, because when we've been out in the community before, frankly, we just haven't had enough. There's one of the things that people don't touch on, I think, is, for example, for transplant, even in the dialysis units, I look at a unit, 30% of the people or less are listed for transplant. There's a lot of reluctance. There's a lot of, I'm going to say, we need to understand the patients. And I think before we go out into the community and we allocate resources, let's understand what's going on in our own units that are barriers, not just the obvious barriers. Well, I don't have enough space or something like that. Let's understand what the barriers are to patients really being interested in home dialysis, going on to transplant listing. And
I think that brings up a question from the chat, which I think is a great question for both of you, which is what can be done to deliver more preventative care to communities of color? I know there's an effort now being made to encourage inclusion in the Medicare wellness visit of CKD screening. But how can we get that screening and education out to the community at large?
So I can take an initial stab at that. So I think there's broad recognition that there needs to be more equity in what we're doing, and that starts, like Stuart said, from education, right? I think we need people who are to be more aware of the fact that their kidney disease is a huge challenge, and that unfortunately has to start from providers. We need better recognition of when patients have chronic kidney disease and early stage kidney disease, and better communication of that to patients, right? We are in some ways in a much better position in terms of new therapeutics. I think we have the ability to respond and do better things to prevent CKD progression, and I think that creates an opportunity again to interact with primary care providers and ensure them it's not just the challenge, I think, for primary care providers when they're overwhelmed and they have so many things that they're needing to do for patients is, it's fine if I recognize chronic kidney disease, but if I can't do anything about it, I have so many other things that I need to address. I think with SGLT2 inhibitors, with the fact that we now have ACEs and ARBs, and we now have compelling evidence that shows that we can use these as combined strategies to do things to delay progression of disease, we now have the ability to go back to primary care providers and be like, here's an opportunity to intervene and discuss these issues. I think that represents a starting point for us. And I think the fact that the payment model specifically call out equity, I think is another incentive for nephrologists to start to pay closer attention to how we are doing this for our patients.
Great, thanks, Sumit.
I think one of the things that we're interested in doing is we have we're alluding to what Sumit is saying. Our patients are generally further along with the programs that we're involved with now, and that's, as you said, Sumit has said also, we're starting a little bit late. If we're at stage 4, we're on dialysis. But one of the things we can try to do with education is not just educate the patient, but engage the families, because the families, in fact, are potentially high risk. Contain high risk individuals, or as Sumit has alluded to, we're going to see subclinical renal disease. And so what we want to try to do as we establish the Llewellyn Center, again, is we're going to engage not just the patients, but also their families and educate.
Great, thank you.
Jeff, we have a question that maybe follow on from that. For those patients in the lowest economic group who do not get on the transplant waiting list, could comorbidities make them poor transplant candidates, such as they are not listed? And could we demonstrate that this is related to less access to good medical care prior to the initiation of dialysis?
So I can take that. So we've looked at this, and this has been a raging debate in the kidney disease community for many years, right? Is what proportion of the ESRD population that's not on the wait list are actually good transplant candidates? And that number, that estimate has fluctuated wildly. I would argue that the most recent analyses that we've published, and Jason would suggest that the vast majority of patients are actually candidates for a transplant, that we are leaving some of our youngest patients, so patients who are in the 25 to 45 age group behind, with individuals who have few or no comorbidities, are not being provided enough education about transplant, the benefit of transplant, the fact that they should be advocating for themselves as well for potential living donor transplants. So I think that's a fig leaf we've hid behind, that these are patients who are too sick to be waitlisted. And just as an example of what we've not done well, is that we've rapidly increased the proportion of patients on the waitlist that we delist, right? We remove claiming that they're too sick to be transplanted. So Joel Adler and his group has shown recently that the median survival for a patient who is delisted from the transplant waitlist in the United States goes on to live for another 5 years, suggesting that we're delisting people too quickly and we're being far too selective. So while we're all very happy and patting ourselves on the back that our transplant long-term survival rates are improving dramatically, part of that has become the end result of being overly selective about transplant candidates and overly selective about transplant organs, which also leads to the challenge that we have, other challenge we have down the road, which is discards. But I would push back and say, I don't believe it's comorbidities. I think it's because we're being far too selective.
I think that's a great point, Sumit, and I think that it gets to the idea of our inherent biases as clinicians. And I think that, Stuart, maybe you want to comment on this, that's not only the case for transplant, but for home dialysis as well.
Yeah, what I wanted to say is I agree with what Sumit is saying, but one of the things, and this is where the wellness ambassadors are teaching me so much, where we go into the dialysis unit, and when I go to a Brooklyn dialysis unit and 20-odd% of the people are listed for transplant, it's not necessarily comorbidities. We have to understand other aspects of patients to get them involved and get them engaged to list for transplant. And I absolutely agree with you about the comorbidities. There are not a lot of people we can't transplant pragmatically. Certainly not when you see, when I go into a dialysis unit in Brooklyn and only 20-odd% of the people are listed for transplant. We need to overcome barriers. And that's where I think I'm hopeful that by understanding the cultures in the units, we'll also be able to work with our wellness ambassadors to encourage people to be listed for transplant. That's why I made the point, if you get listed and you don't want to be transplanted, say no. That's okay too. But let's get these people, let's get everybody engaged.
Yeah, I couldn't agree more. I think you're absolutely spot on.
So Diane, I think we have time for just about one more question.
Dr. Mohan, there was a question which I think you might have answered in the chat box, but I'm sure people are interested. I think the data that you presented on AKI was pre-COVID, and what has COVID-19 done to that data now?
So yes, the data that I presented was pre-COVID. We don't currently have a huge amount of AKI data, national data on with COVID. What we do know is the following. So we do know that there was a dramatic increase with renal complications with COVID. We know about a third of hospitalized patients early in the pandemic developed AKI. Whether COVID directly infects tubular cells and causes renal injury, or whether it's a artifact of the way the ARDSNet protocols were being used early in the pandemic is unclear. But we also know that AKI incidence associated with COVID has been coming down. And one of the early concerns in the pandemic was that we would see a large burden of ESRD and CKD, secondary to severe AKI from COVID. And that does not appear to be the case, at least not ESRD. We're still waiting, obviously, to see what would happen in terms of CKD and whether these individuals are going to have full recoveries. But we're not seeing a large bolus of ESRD secondary to COVID, which I think is reassuring.
Great. Well, thank you all very much. I want to thank all of the participants. I want to thank you all for joining us today for the first part of our symposium. And to remind you that the second part, which will address disparities in the diagnosis of CKD and its risk factors, will take place on Wednesday, November 17th from 12:30 to 2 p.m. I again want to thank Dr. Saul, Dr. Mohan, and Dr. Webb. And I'd also like to thank our team who put this project together, Tanya Citrone, Susan Spiegel, Peter Kapar, as well as Julia Ishari and the Dalio Center, and David Wyman at Rogosin for his support as well. Thank you all for joining us, and I hope you enjoy the rest of the day and your weekend.